How are you? Okay.
Okay, so just turn it sideways. I can stand here. I'm gonna stand in front of Demetria. I'm just gonna stand right in front of you for a second, and then I'm gonna pass over to Channing to run the rest of the show. I'm just gonna do my like words feel. All right, then. Thank you, everybody. We're gonna give everybody just a couple minutes to get logged in, settled on Zoom, and we'll get started in just a minute. I'm going to get us started because we have lots of great speakers today and plenty to cover. So I'm Sarah Brewer, I direct our education program at Boards, and we're welcoming you all today for our seminar / panel. For those of you who are not familiar, Boards is a one-stop shop for faculty to conduct pragmatic research, receive various types of services, supports for their grants and projects, and get incredible mentorship, training, and education in health services and pragmatic research. Using some of our many offers here, and I particularly want to point out on the ecological tourism programs series that we partnered with our Colorado program and Patient Center. I have such shared decision making that I'm really listening to their names. So I'm going to highlight just a couple of our upcoming offerings. So our other series right now is our statistical methods in pragmatic research. And we have Brian Peterson and Keith Kohn talking about pragmatic statistical learning. If you are interested in some of the machine learning and data topic area, that's going to be a really interesting talk. And also in April, we have joining us. And then the next and last in this series is going to be April 3rd, and that is focusing on training clinicians and shared decision making with a particular case example. Before I hand things over to our panel, just a couple of logistical items, especially for those folks who are on Zoom. Please go ahead and use the chat or the Q&A function. We will have time for Q&A at the end. Also for those of you who are here in the room. And then if you are here in the room, we have evaluations on the material rights, where we can go take a couple minutes and tell us what you think about our seminars. For those of you who are online, we'll put that link in the chat as we get closer to the end of the seminar today. Right. Moving on to one last announcement. Kohn, our pragmatic research and health conference registration is open. It's June 5th and 6th. It will be virtual. You can register anytime at kohn.com. All right, on to the most important part today. Today's seminar is part of our ethics challenges and decision making series. It's the 5th at 6. And we welcome Dr. this week, Demetria, Bolden, and Miria, and and they're going to be talking about critical conversations, health equity considerations for working with diverse communities. And I'm going to begin the rest of our session with Tate to moderate. Thank you. So thank you all for being here today. We're going to have a very discussion. So the way this is going to work, sorry, sharing myself. I'm an assistant professor in internal medicine. I also look at sports, and I'm a faculty member in the Power Program for Smart Decisions, which is a lab here at a course that focuses on shared decision making between teaching patient facing decisions. So most of my work is in underserved populations with the decisions that I make. So the way our panel is going to work today is we're going to briefly introduce some recent colleagues here. They're each going to give a little bit of talk about some of the areas that they are specializing in. And then hopefully we'll have a very rich discussion. So I have some questions that I'm asking that I hope that you all have listened to. So to start, I would like to introduce Dr. Demetria, who is an assistant professor in internal medicine, and Dr. Bolden is a communication scientist and facility researcher. Dr. Miria, sorry. Okay, Dr. Miria Kano, who is an associate director, the associate director of DIA for the division of immunology, biostats, that's not right. That is not right. That's not right. That's right. Yes. Well, it's true. That's right. That's right. That also says researchers and communities of cancer studies. And then we have Dr. Lucinda, who's an assistant professor in dermatology here on campus, and her research is in Native American or American communities. So I will bring it over to my student colleagues to further introduce themselves. Thank you. So it is my pleasure to be able to speak with all of you today. Oftentimes when you think about shared decision making, we sort of put it in thoughts, and everyone wants to just play it out in thoughts. But the foundation of shared decision making is communication. And my terminal degree is in communication. So I have not only appreciation for it, but a little bit of expertise from it. And even though I may not call it shared decision making, or label it or shared decision making personally, it absolutely is sprinkled throughout that I do, as I often will evaluate communication in the process. So in the short amount of time that I'm going to speak, we'll specifically want to talk about shared decision making in my work as it relates to cardiovascular disease, gaps in care for what's called peripheral artery disease. Next year, so not picking up as long as last year. And lessons learned and still learning about decision making and community-based research. So I thought I would ground everyone as it relates to a path to shared decision making. So there was a statement released just a few months back, and several of the colleagues here at the campus were on it, including Dr. Miria, and they talked about shared decision making in cardiovascular disease. There was a national statement that was released, and a couple of things that I wanted to point out that I think were very interesting. One is just the definition. Everyone is here because we really understand and we appreciate shared decision making, but it is a communication process, which is sort of what I led. In which patients and clinicians collaborate to choose tests, treatments, and care plans that are most aligned with the individual patient's preference and values. And I think that's really the question when we talk about where is the patient's preferences and values, and ultimately the decisions that we are making toward their clinic. Something else that was very interesting. There's a study that was conducted that looked at decision processes and what are the conditions and or diseases in which there were lowest scores as it relates to was there effective shared decision making occurring or not. And
Unfortunately, there were 5 that sort of scored the lowest. One was breast cancer and prostate cancer screening. Unfortunately, it's probably not a surprise. We've heard that often. Most of us have worked in that area, but also in hypertension and cholesterol-lowering medications. So even something as simple as those types of drugs, most patients do not feel like there is any sort of decision or even really a discussion. And then we talk about screening for colon cancer and then cancer. So when we think about these areas and where decision making doesn't happen, it does give us hope that this is an area that we need to continue to investigate and also explore beyond the data that we have here and be the impetus for us to share and move forward with them. The other point that was made that's very interesting is that there's a considerable journalism that still exists in the medical system. We all know that that sort of happened, but even now it still sort of exists. Either one patient's default to their provider to make a decision, or there really isn't much discussion around the choices that are made. So I wanted to take a moment and tackle considerable gaps in recommended care for a disease called peripheral artery disease. This is sort of an area I work for right now. But something that's really interesting, this just came out in the last 3 years or so. And you can see in the table from this article, you see the recommendations, right? So American Heart Association, American College of Cardiology came together and they said, hey, these are the guidelines for this particular disease. And when we talk about adherence, there's considerable gaps. When you talk about aspirin, statin prescriptions, antihypertensives, they're all significantly lower than recommended. Also, when you talk about something that we may say as simple as smoking cessation, doesn't the pharmacotherapy that's associated with smoking cessation doesn't happen. So then you have to step back and say, well, why isn't it happening? Why isn't the conversation happening? Why isn't the patient included in this conversation? And how can we do it? So the work that I do that works not only in the academic setting, but also in the community, there are some lessons learned that I wanted to sort of talk through and go through. What are some of the learnings, specifically from the voice of patients that I've been able to gather? One is recruiting populations. Now, this may sound very simple, and everyone sort of understand. Oh, we know that they're different, but because it's not just by racial lines, right? Let's not simplify this, right? Oftentimes, recruitment goes beyond a racial group. It goes beyond socioeconomic status. It goes beyond level of education. It really should focus on the context and the circumstances by which people are living their lives in there. Because oftentimes, if you were, for example, to remove the level of pigmentation and just look at the circumstances by which they're living, you could really get an understanding of how their life is lived based on the condition by which they're having to live. You get a better understanding of this. Promotional strategies. What I will tell you is I've had successful recruitment, but it's been because I've had what I call inside. I've had the MA literally walk the patient. I've heard them say this, and you need to go talk to her. Like that. Is that a replicable recruitment strategy or promotion strategy? Not really, right? But it's effective. With that said, you have to really be able to meet your target audience. What are they listening to? Where are they physically located? Things like that. There's a woman that I met at a conference that I attended approximately 2 years ago. And it's a really idea. And a word we could call it. She actually has a laundromat-based healthcare business that pairs healthcare insurance providers with laundromats to come and help people get insurance. She has pharmacists come to help patients talk through medications, all while they're in London. It's good. Because that's the target audience. That's where they are throughout the week on Saturdays. That's where they are. I also need to her the price of the clothes. Like I didn't know. I've gone to a laundromat in many years, but she said it was up to like $8. I was like, and the whole room was like $8. So okay, just let's get a washer. Like that is expensive for but it's a brilliant business, but also a strategy to not just recruit because you're right there, but also to promote it because it's grown so much. The word of mouth, everyone in the neighborhood was talking about the service that we also built trust with the community. So we're doing that. Ongoing engagement is design. This sort of lends itself on the example that I just shared. I subsequently also have learned from working with in the study that I have from the patients that we've been able to recruit, as well as something else that I'm sort of starting up, is that people want to know something and not just sort of for the right. Ongoing engagement is key. They kind of want to know, how did this start? Why are you here? Why are you talking to them? Sort of what happened. Like it's over the woods, it's over the right? Is that something too? Oftentimes, even when the sunset, most people they don't understand. You say, well, the grant's over. No, you're not right. And they're like, well, no, like this is what we're doing. I thought this is what you're doing. And it's like, you're not doing. And then that becomes our responsibility for advanced sustainability, which we're not interested in that. But that's also something that I focus on that can help with the transition. Identifying what is modifiable and actionable and so on. So oftentimes we sort of do things over on to the next. And what I found, especially in the community-based things, is it's really helpful to understand what actually can be changed here, what actually can be improved here, and work with the community to put that into action, so that they have some sort of tangible proof that this work is good. Lessons that I'm still learning. They just want to learn more about their business. I work in disease and approaches where there is extremely low knowledge and awareness among the community organizations that have it. That's not exclusive to that there's many diseases where patients really just do not truly understand how they got a particular disease, what they need to do to get them to etc. They also want to understand their benefits. Oftentimes they will say, well, you know, my doctor said X, and they don't understand. And they're just confused about it, but they sort of don't do anything with the confusion. They just say, well, I'm confused, and they just kind of hold it. They patients want to improve their health. I think oftentimes when the research is reported, we say, oh, the patient is not applying for the and so there's always this, well, whose fault was it, whose blame was it? And I think what we have to all appreciate and understand is that if we were to stand anywhere on a global space and ask the question, because we will not for help, no one's raising them. So we have to err on the side that yes, people actually want to do their work, and if they aren't, there are contextual and structural factors at play that are in their mind prohibiting them from this. Patients want to be seen and heard and not their condition. So oftentimes I've heard from patients that are describing whether how they need to become diagnosed with disease or their experience through the healthcare system that they are seen as their condition or their disease and not as a person. And that makes it difficult for them to connect with just the healthcare team. So I think that's important. The patient voice really is the basis for why we do it. It serves as the foundation for change, for intervention design, implementation planning, dissemination strategies, and connection, as well as the sustainment system. Their voice matters, and it's really important. So what does their voice sound like? These are several quotes that I thought resonated with my purpose here today from patients. Let me be clear, these are a lot of them and diagnosed with referral disease. And so if you're a patient, for example, not knowing what causes the PAD, Not sure on that either. I know that a lot of what I've been told over the years is that the root cause of everything going on in my body is high blood pressure and diabetes. Right? Someone else mentions, I don't even know how to get this part of the disease. How do you get it? Is it something genetic or something I've done to myself? Another patient said, to know why that disease came, why I have that disease. Nothing like that had ever happened to me. I don't know why that happened to me. So there are a lot of patients that live with conditions and they have no idea how they came to diagnosis with a particular condition. That's why we have many numbers. But it also can contribute to the poor outcomes that we often report, but we never tell this, right? We just say, oh, this is a preventable death. But we never say that the patient with the condition that we didn't know. So how can you manage something if you don't know? So what you have the patient was going to do. What if you do? That's what happens. You use it to have the ability to change the laws and the policies that we have for me. And you use it to expand the research. Methods you have, it has to wider, it has to broader. And also, there's great ideas, and they want the patient to be better. But the problem is, all kinds of great words. So they kind of know what to do. So how do you use it for and I'll leave with, this is the quote from the article that was just published on that statement from the age of share the situation. As a driver for I thought it was just most appropriate because it says multi-level solutions must align to address challenges in policies and reimbursement system level leadership and infrastructure, clinician training, access to decision-making, and patient engagement to fully support patients and clinicians to engage in the shared decision-making process and to drive equity and improvement in cardiovascular health. And I think that is a great direction and positions to not only understand and appreciate those community, but understand that it can be applied as we think about it. So that's all I can do. It doesn't have
Just sounds like, yeah, love that. Just do your best. But I just want to let you know, I too might come in and like mess with it.
Okay.
That was amazing. I have like Jim said that I'm a pediatric dermatologist. I work at the children's hospital here, but I also have a dermatology clinic in Chile, Arizona. It is in the middle of the non-hospital where I do and so in my piece clinic here, we do like eczema, and then so just a little bit more about me. I'm training with anything that's more research with the American Indians. And that is because my husband is a member of the and I have been and the picture on the bottom is me at Pro Care. Before we had a child, we used to stay in peace, and that would always be with RCD. It's really hard to say without and get a child to sleep at Pro Care. He wouldn't be around if he did it like so long, getting like this was bad. Before then, we do stay with him. And For this talk, I was really gonna focus on really tangible lessons as well as in my research, working in things. So not really about really, solid concrete advice about recruitment, compensation, and also community. So right now, I'm actually wrapping up a study, it's a qualitative study, I do it, and we had it in my clinics at Bolden, where we, interview families about their barriers and facilitators to specifically accessing and food services. And the reason why I wanted to do the study was because, it felt like we weren't really serving our families very well. The resident of the patient really, I walked in and before I walked out, wait, your pharmacy is where? Like, where is this in Colorado? Oh, you can make hours a day. No, you can't come back for follow-up in 2 weeks. Like, that's too much. That's such a cost. And so I wanted to get a research level of understandings of what people's barriers and recruitment was really hard. So we were trying to recruit children from underserved and diverse communities. And I think most people would say this is a very hard population to recruit. They do not have an hour of time to interview with you. And that's what we found out. So we started recruitment in the middle of October. Okay. And we recruited no one in October. Okay.
Yeah, it's good now.
Hearing in the chat that it is working.
Yeah, it's green now. It's green.
Great.
And this continued on in November, and I have a medical student working with me this year. We need to publish, we need to get this project done. I was really worried that we wouldn't be able to recruit adequately for this study. We wanted 10 families from our Black community, 10 from our Hispanic community, and 10 from our American Indian community. And so we were worried that we wouldn't be able to recruit. And we ended up needing to implement some changes to increase our recruitment. And so what we did was, first, we started using Calendly. Before we used Calendly, we just had a qualitative researcher. She would contact the family in whatever way they wanted, text, WhatsApp, email, and then there would be a back and forth of like, okay, when are you free? When am I free? Okay, I want this time. And there was a really big back and forth that happened. And parents of young children forget to reply to texts and emails, and they can't wait. Like, I mean, I have a young child. You live in the moment, or you forget. And so Calendly was a way that they could just see their schedule right away and like schedule the interview and get a link right away. So that kind of helped overcome that hurdle. The second thing we did was we actually opened up our interview times to weekends and evenings, and we had about 6 families who chose these other times, and early mornings as well. So it was early mornings, lunchtime was popular, evenings and weekends for these families. We also sent text reminders the night before. Initially, we had a lot of people like dropping out. They're just like, oh, my kid got sent to the principal's office. I need to go to the school and manage them, or I forgot, or whatever. But with the reminders and also being able to have them schedule on their time, it really helped help them schedule. And I think also having them be able to schedule in a more short-term manner, like I know when I'm free today, but I don't know when I'm free tomorrow sometimes, that also helped people engage in these interviews. And so in the month of December, we recruited 20 families, and we did not interview between Christmas and New Year's. Another thing we did for them was we compensated them $75 in Amazon. I think some of these families are probably motivated to get the money to buy their Christmas presents for their kids. There was one family who really needed that money, and so I was sending her that gift card on Christmas Eve to help her get that compensation. And speaking of compensation, it's really important to pay your participants in the way that they want to be paid. And so another study I did was I surveyed teenagers and adults at powwows. And powwows are large community gatherings. There's dancing competitions, drumming competitions, vendors come, artists come, they sell all of their artistry. There's food, there's clothing. It's a really big deal. It's where the community goes to gather. There's prayers being said too. And we wanted to be here to recruit these American Indian people, and we wanted to ask them about their skin conditions and access to dermatology. And because I really wanted the teenagers to participate, I wanted to pay them in cash, because what teenager has an Amazon Prime account? No one. So, and plus they're at this powwow, they can use their $10 on food or on trinkets. And so it took a lot of work, and a lot of people told me it's impossible, don't even try. But there is a mechanism here at CU where we can pay people. It has to be a pretty low amount, so $10 was perfectly fine. I had to get IRB approval. I had to sign a bunch of forms with the bursar. I had to basically sign away my life and blood, but then they gave me money that I could hand out. And so over 2 powwows, which is basically 1 weekend each, we were able to recruit 239 participants.
Amazing.
Yeah. And then lastly, it's really important to give your research participants in the communities a voice. And so one way to do it is to form a community advisory board, which would then meet at a certain frequency and help you with your research. This is something that it's easiest to do if you just write it in your grant, and you need to pay them too. And so I'm writing a K award right now where I'm forming a CAB. We're meeting quarterly and they're being paid. Each person is getting paid $50 because that is what I can afford. I wish I could pay them more, but at least $50 per hour for their work and expertise. Another way is to involve them in qualitative research. So their voice is the data that you then present to the world. Going back to the study that I'm doing with my own clinics, we've had some really poignant stories arise. One example from Demetria's talk about understanding the healthcare team, like most families do not understand what a resident is and why a resident has to come in before the attending and what are all these people. Usually they go to their community clinics and they see one nurse and one doctor, but here we have an MA, we have a nurse, we have a resident, sometimes we have a medical student, and then the attending comes in. And by then they're like, oh my God, who are all these people? Can my child get dressed again at some point because it's cold in clinic? And so that's something that we're actually addressing, is teaching families who their healthcare team is. Another story that arose, speaking of social determinants of health, is you don't really know where people are coming from. So we had a family say, we had to skimp on food and groceries for 3 months to save enough money to make the trip to see you in clinic. So they like cut back on their groceries, they saved, they had to pay for a hotel, for gas, for food for the trip, for a 15-minute appointment with me. And that is just humbling to hear that they were thinking about this appointment for 3 months for my expertise in 15 minutes. And so, especially for our families who live far away, I always offer, like, you can always message me in the portal. Please send me pictures. And we always gripe about the in-basket, but I think for some families, it's better than having to save for 3 months to come see us. And then finally, I wanted to touch on forming a patient family advisory board. So I'm also currently doing this with the Children's Hospital. Patient family advisory board is different from a CAB because it's not just about your research. It's a group of people who can help guide the hospital and the clinic on what to do on decisions made. So for example, one decision that has come to mind is the hospital wants to acquire art. And is this art, does the art vibe with the community? And so this is a really slow process at Children's. It's like a 7-step process. And step 1 is to form a steering committee to then decide on how you want to form the patient advisory committee. And because I work with American Indian communities, which I love working with this community, but we decided that us as a steering committee wouldn't know. So we decided to do a listening tour of all community leaders to decide on what to do as a steering committee. And so we were just wrapping up that took 6 months. And it was really fun. We listened to people who were like the directors of Boys and Girls Clubs for tribes. We listened to community pediatricians and neighboring reservations. We listened to Denver Indian Health and Family Services here in Denver. And we learned a lot. We learned that traditional monthly meetings in person would not work for this patient population. We also learned that Zoom links would not work. So we are thinking about doing a once a year gathering of people where they would meet hospital leadership and decide things that way. Everyone said that we had to compensate our family members. This is a PCORI like principle that you compensate your participants in that way, expert participants in that way. It is not in our children's hospital policy to do that. So we were going to have to get creative, but we will be compensating people. And then I also learned that consensus and collaboration take a lot of time and energy, but it's important to do. And then just a final note, for people who work with tribes, it's really important to expect the tribal process for doing research. And so the picture on the left is actually, so I also did a project with the Navajo Nation, and part of the process of getting IRB approval with Navajo was you had to present your research to the community. So the picture on the left is I took that picture at a town hall meeting where I presented my research to the community. They voted on it. And then after approval, they gave me a letter, which then I presented to the IRB. And the picture on the right is a picture of the IRB gathering for Navajo. So it takes a lot of work, but it's rewarding and it's good to do. So in summary, compensate people the way they want to be paid, give your participants a voice. Consensus building takes time, and value tribal and community organization processes for doing research.
Well, thank you. Thanks for having me. So when we were talking about this, we were thinking shared decision making is challenging. We all work with these diverse populations, and it's hard to jump into shared decision making without understanding the context of the populations with whom you work. So mine is kind of a deep dive into working with the LGBTQ population. I've worked with these communities for the last 20 years. So it's definitely my just what I'm passionate about working in. I'm a member of the community also to put a stamp on it to let people know. So whenever I go into the community, I get to know them very well. I'm new to Colorado, so I'm looking forward to meeting more partners here. But New Mexico, a lot of people knew me because I have been working in and out of the community for a very long time. So this is about engaging diverse LGBTQ folks and people in cancer health research. That's my primary focus. But I always have to think about this and starting about why is this a health disparity? A lot of people think, oh, LGBTQ populations, there's no health disparities. They're the same as everyone else. So I thought, let me just, put a point on that quickly. So there are several disparities. There's a lack of LGBTQ cancer research in general. It's a very young field. It's like within 20 years, we've really begun to develop that. Lower rates of cancer screening, lower satisfaction with cancer treatment, higher rates of psychological distress and survivorship when compared to their heterosexual cisgender peers, gaps in patient-provider communication. So this is where shared communication comes in and is a crucial issue. Body image issues and eating disorders, and then health problems for LGBTQ people who have experienced violence, stigma, discrimination, and all of those types of things that lead to kind of minority stress and internalized homophobia. We also know that translates into these 7 kind of elevated cancer types: anal cancer, breast, cervical, colorectal cancer, endometrial cancer, lung cancer, prostate cancer, and much less understood cancer-related issues affecting transgender. And I have transsexual in there, and I'm not going to give my whole lecture on how language changes. But when this original article came out, transsexual was still a term being used. And now I cite it just because I'm using this article, even though that is a term that is no longer utilized. So, and Gwen Quinn, who's the first author on this, knows this very well. And is mortified that is blazoned in the title of a paper. So this is really important in cancer research because for me, it's usually people that develop cancer, usually our eldering population. And it's crucial to understand those people because LGBTQ elders are less likely to disclose sexual orientation and gender identity in healthcare settings at a considerably reduced rate. Twice as likely to live alone. 1/3 of LGBT older adults live in poverty. They don't have the same social structures that other communities have. And so this is these are always, when we think about intersectionality and intersecting contexts of people, these are just a few of those things that we have to consider when we're working in the LGBTQ population. So I wanted to bring it home by just talking about one little research project that I had done. This was just a pilot that's led to much larger research, but in this particular pilot, it gave me some insight into like how we could develop a shared decision-making tool or patient-centered care, which I just think is patient-centered care. When we come down to it, it's like, how are patients being received in this larger healthcare setting? And so we recruited 10 patients. We also interviewed their 10 informal cancer caregivers. We also did a heterosexual cisgender match. So we interviewed 10 heterosexual cisgender patients and their informal cancer caregivers to see where there were similarities in terms of things that we needed to develop to address healthcare gaps, and then also where there was divergence in what might specifically be something that was an LGBTQ population concern. This was mixed methods. We did interviews. We had originally said, oh, they'll be 1 hour, but when we really got to talking to our LGBTQ patients, they were all 2-hour conversations. I mean, rarely was there anything that was less. And then also we did promise measures, which were really looking at quality of life for all of our patients, so we could compare and contrast. I'm not really going to talk about the whole part of the study. I'm happy to later, or to come talk to anyone who wants me to talk about that. But I wanted to say, like, these are the reasons we have to think about who the patient is when the patient comes into the healthcare setting. Because for me, it's thinking about providing care for diverse populations starts in the parking lot when they pull up, and it goes all the way through the healthcare setting and all the way back out to the parking lot. And if we drop the ball at any one of those points, we've dropped the ball when we have a population that has a tremendous amount of medical mistrust and reasons for having that. So just in this group of caregivers and patients, so 20 people, we had so many stories about patients reporting verbal assaults, walking across a parking lot, loss of jobs, bathroom policing for our trans and genderqueer populations, house purchase issues, and structural trauma, because these are elders, so they actually remember the AIDS epidemic, politics that were really prohibitive and discriminatory, marriage exclusions, and needing to be hiding or closeted, particularly like if they were in the military. And so, they told us very specific things that, I'm 80 years old, I go way back. It was really scary back in the 60s and 70s. Another lesbian patient told us, I've always looked over my shoulder. I've always monitored what I say and how I behave. And then another person said, the part that's toxic is you always have to wonder. Just the fact that you even have to think about it is kind of where you're wondering where the toxicity comes from. It's almost an internal problem because you have no way of actually knowing unless someone comes up to you, calls you a dyke to your face and punches you. And so she says most people are smarter than that. Usually it's really insidious. And that's really the case for so many populations, right? People, we talk about this in Colorado. It's a very, white, 80% white population. I'm also the DEI AD. So this is something I think about all the time. But we have a very progressive community. We think of ourselves as very progressive, but if you're not actively addressing some of these things, you may not be as progressive as you think you are. These are things we have to interrogate about ourselves all the time, particularly our healthcare settings, our healthcare providers and things. This led to conditional outness and openness. So if we don't know who our patients are that are coming in, how do we know what the shared decision-making tool is for them? When we asked one woman about her, are you open? She said, no, not really. I don't walk around with a sign. When I'm with someone, I don't even know if we'd hold hands. I'm always careful about my safety, and I've never felt totally safe. That's the way it is. And another person said, it's not consistent being able to be out. It's been challenging to come out to certain people, to doctors. So it really is this, like, the context that everyone's referred to here. And with this population, it's age, social norms, and prior experiences. So we can't just look at people and make that assumption about who they are. It's impossible unless we're talking to people to get them to tell us. And so, other prior experiences really informed who they were coming in. And so this story of so it's a lesbian couple, but one is genderqueer, so very gender nonconforming in appearance. says, we asked our provider, are you okay working with a lesbian couple? Because neither of us really trusted that she or any other medical professional is, because people have all kinds of stuff. There's a lot of religiosity, even among doctors and healthcare professionals, where they have biases, and those biases come out. We wouldn't have had to do that if we were a straight couple. So even before they get in and start making decisions, they're wondering, are they okay being there? And then this is the other point I wanted to make in terms of shared decision-making. This is a lesbian caregiver who had a really horrible situation. She was trying to make her point known to the doctor with whom her wife was getting treatment. And she said, I didn't feel seen. I kept trying to connect with name of the doctor in a way that would validate me, acknowledge me. I said, I work in the hospital. I know the system. I lost my sister to cancer and I was her caregiver, but I never got recognized as somebody. It wasn't worth fighting to try to impress my point. I just held on to my observation. I walked out of there feeling like I did everything but stand on my head to get acknowledged as somebody. It made me so angry. I bring that point up because when we talk about shared decision-making, we are usually thinking patient to provider, but what we're not considering is caregiver, and caregiver for cancer patients in particular is really crucial, because for those first appointments, when I do a lot of cancer patient interviews, they say, I don't remember anything, talk to my caregiver. Like the trauma of having that cancer diagnosis is so much so that that kind of just shuts people down. And so the people that actually are the ones recording that interaction and helping to make those decisions are the family members, the loved ones. And for LGBTQ populations, it's informal cancer caregivers that aren't necessarily their family of choice, or their natal family, it's their family of choice. So it can be someone who's a partner, not necessarily a married spouse. It can be someone who's a friend from the community or someone from another larger part of that community. So we mapped spaces for intervention that would promote shared decision-making. And we really saw that. I'm a medical anthropologist. I guess I should have said that. So I really look at things in this kind of like multi-level way. And so we mapped all of these different areas that we wanted to really intervene on to help promote shared decision-making. With the providers, like these are the tools you can use, but also with the patients to say, here's how you can advocate for your loved one, for yourself. Here's how you engage in that conversation. And to do all of that, this takes community engagement, as you said. And so I put this, nothing about us without us, which comes from the Salzburg Global Summit in '88, but this is still, or '98, but it's still a really crucial thought. If you're developing something for patients, you include the patients with whom you're working. And now that I'm in Colorado, the people here will have very different issues than the people in New Mexico, where I was for 27 years. So I know that now I need to reorient myself with the communities here to say, what are the issues you have and you see? But it's when we think about building a community advisory board for LGBTQ populations, I don't think of community as just the community member, this isolated person. It's the community, it's the broader community, it's health advocates, researchers, healthcare providers, policymakers, bring all of the people to the table that actually can help move something forward about creating health equity for people through the tools. And then also, we've talked about how do you do that in terms of, and I'm going to hurry because I know we need to get to the end of this, but developing trust, all of these kind of core principle pieces that we have, put that at the center of all of that work. And I also just present this as like, these are the things we consider before we create a community advisory board. This is our thought process. Who's there? What are the socioeconomic factors? What are the national level policies? This is huge. I do a lot of national studies. And now 3 of the places I work in have anti-DEIA and SGM policies very actively, Texas, Alabama, and Florida. So it's very important to know about those things. And then who do we need to do? How can we move that? When we talk about sustainability, these things are crucial. You can roll out something, but if you don't have a plan for how that stays in the community and works, it won't work. And so, the community can help with all kinds of things. You really did a great job of pointing that out. Like, how do you recruit? What's the research question? And engage them early and engage them all the way through, all the way to dissemination of the project findings. And then I also wanted to say that this engagement, a lot of young, kind of like junior researchers that I'm talking to say, what you're proposing is so hard. How can you do this? I can't, get a grant that's going to pay me to do community-based participatory research. It's very expensive, time consuming. So this is just a map showing how you grow community engagement and maintain consistent community partners and how it can change. I started out in behavioral health and primary care. And we built something through a PCORI grant to have, summits for LGBTQ people, for providers and for patients. We've had 8 of those summits. When my grant ended, a community partner from New Mexico AIDS Cap took it over. So he fundraises for this. They're still doing it, even though I don't even live there anymore. So now that's still going on. And then they said, cancer is an important thing. So we did this, but we also went SGM, we went principles for primary care, best practices for patient-centered care. So we wrote a grant about that. So it can change. You really have to listen to what your community is telling you, because that's really pivotal for this type of work. And so now it's resulted in a multi-site R01 that we're resubmitting because the government shut down on a fundable score and we didn't get our money last year. So now we have to resubmit. Yeah, I know. It was very frustrating, but we're resubmitting now. There's another FOA that's like perfect. So we're excited. We'll resubmit in May. So anyhow, and this work is not something I did by myself. It takes a village and a ton of partners and different vendors to make all of this happen. So thank you.
Yeah.
That was really, really inspiring. So I think you all actually answered the first question I have for you. It's some cross-cutting themes across all of your presentations. Took me back to junior high. Who, what, when, why, how. And so the first question is really, can you do health equity work? Can you do shared decision-making work without community engagement? Can you do it without knowing who the population is? And Demetria very eloquently said it's beyond more than pigmentation in your skin. Lucy talked about that family that had to give up everything to come spend a day with her. Miria talked about this thing that's been on my mind a lot, like this sense of belonging. How are we servicing people if they don't even feel like they belong on this campus? And Lucy spoke to that too with like the artwork. How can we help engage our communities? Also, this idea of the continuum. So making sure you engage people early throughout the process and often to keep them engaged, because they want to know. And how do you access these hard to reach communities? And also understanding that each community is different and there are many intersectionalities within each community that we all need to be aware of. So this work takes time, it takes a lot of effort, it takes a lot of resources. But my question to you all is, can you do this work without community engagement? And I think you all answered it.
Sure. No, you can't. It's for the community, and if you don't work with them, they're gonna reject your work, they're gonna reject you. And so why would you try to do it without them? And speaking of like, how do you engage with these communities? A lot of it is just about showing up over and over and over and over again. Like my relationship with the Navajo Nation took 3 years. And like some of it was on my own dime. Like I just flew out there on my own and I just showed up for like a half day and I left and they were like, wow, you like took a flight and drove 3.5 hours to see us. And I was like, yeah, because like a phone call is not going to do it. I just have to be here in person. And if you keep showing up, they will realize that they won't lose you and they'll be more likely to do work with you.
I totally agree with that. It takes time. It's always not, I say all of this begins before you even think of your research question. Half of the trust that I built with that community is going to things that matter to them. When the community was protesting Drag Queen Story Hour, we all went to Drag Queen Story Hour, my family and I, and we stood on the lines and like blocked the hateful people with the signs. So a lot of people saw us, you know, helping at that level, but also at fundraisers, we show up, we, you know, invest. And then also just keeping, you know, coming around. So, you know, if they know who you are, if you come to them with a research project and say, hey, I'd like to do this research project, they're much more likely to say yes.
Yeah, I echo everyone's comments. No, right? The short answer is no. But I think what is truly a gift and the value of the community engaged work is that you have, or you're in a position to acquire a better understanding of people. Because oftentimes you just want to have an intervention and say, I'm just going to implement it. And that's just not how life works. Because everyone lives life differently. And so you cannot just plug and play and say, oh, well, it just didn't work in that community. So something's wrong with that community, right? Because it's easier to say that, right? It's lazy to be able to say, well, that community just didn't work for them, but it worked over here. Well, how do they live their life? Because obviously this part of this particular intervention didn't work for them and how they live their life. So it's not like I don't want to use this intervention to improve my health, says no one.
Right.
It just doesn't work for how I live and walk through my life every day, right? Even when we have good intentions or we say, oh no, this absolutely should work. Oh, I'm going to give patients a bus pass to get to the medical appointment. Well, guess what? How far is the bus stop from where they live? How far is it? Are they in a wheelchair?
Do they have to take a day off of work to use that
Right.
bus pass?
And when they take that day off of work, is it a sick day or do they lose pay for the day? Right. So then we say, oh, well, the bus pass, the program didn't work. That's not the whole story of what happened here. Right. But that's the part that we report. And so when you connect with the community, you're able to understand that part of it. And that way, when you do design interventions and you're doing it with them, you're able to account for those kinds of things that often just get overlooked.
I don't be mad at me. But I'm gonna speak for our panelists and say, I know that we're short on time, but we are all very accessible. So if we don't get to your question, please reach out to us. We're here because we care. So I know Sarah has a.
Do you have a speak?
I can read it.
Questions in the chat. I'm gonna focus on. Focus for you, Dr. Kano. Can you talk a little bit, having just sort of moved from. What are the first stages where we build that community base and understand this new context? What are some of the first steps you are undertaking?
Great question. Well, first of all, reaching out to colleagues that are doing similar work. The first thing I did, even when I was doing my interviews here, when they flew me out, was to go through and Google everyone who was doing any kind of LGBTQ work. And I would meet with people and they would say, how did you find me? And I was like, publications from 10 years ago. Didn't matter. I tried to meet with everyone. So I would say, you know, this is really important. Are there areas that you are still interested in? What do you see in the community that needs to be done? And then also going to LGBTQ community centers and working with different organizations. Nonprofits are an amazing way for you to do something that feels good and to help give something, whatever they need. And I keep a toolkit basically that I say in the back pocket for whatever they want. If they need help with grant writing, if they need statistics, I help find information they need for their grants. If they need a grant editor, I will do stuff like that. If they want someone to come cook for the kids that are at the drop-in center to watch a movie, I'll come out and bring dinner. So it's basically like you have to put your sweat equity into building those groups. So those are my first two steps. And then also just snowball. People will say, oh, you're doing this kind of work. I know this person, but you have to get out and talk to people in order for that to even be a possibility. So you have to get over shyness, you have to get over awkwardness, and you just kind of have to go make yourself useful. Mm-hmm.
There is another, the other one. Do you have any thoughts regarding the difference in mindset between academic campuses and doing this kind of work versus the corporate health system and the need for revenue generation? How some of this health equity and shared decision making fits in those contexts?
Business. No, so thank you for the question. Just teed that right up. So here's the thing, because I often grapple and butt heads with people on this, because I always consider the business end of it. Because whether it's a nonprofit or not, you have to keep the lights on. And we can't act like you don't have to keep the lights on. However, there is this thought that, well, in the academic environment, we just all want to build it and give it away. And that's not really true. We may act like that's true, but it's not, because we have to keep the lights on. And so I think when you talk about corporations or the larger healthcare systems at play, or even the healthcare insurance carriers, the approach is very, very different. So how they go about doing it, and whether they say it's for profit or they're greedy, or however you want to label it, that's sort of one soapbox I don't need to stand on. But at the end of the day, the common goal is improving health outcomes. The common goal is ensuring people live and acquire their best health, their best self. And even if you walk through the muck of greed or profit or whatever you want to label companies as, if you come back to that as the foundation for why you do what you do, I think that you can find common ground. And that's the foundation by which you move forward. So I don't think it's you have to pick a side. I think you have to say, this is ultimately what you have to achieve. This is your goal, and financially, whatever that looks like. And this is our goal, whatever that looks like, but it's still grounded in patient health. That doesn't change. So being able to come together and figure out, how do we connect with that in mind, and everyone can still achieve their goal. But you have to first you have to understand it. You have to be open to understand it. You then have to understand it. And then you get creative about, what does it look like for us to integrate the goals of both sides?
Can I add to I will also say that diversity initiatives are all ingrained in the way we get our funding. Cancer Center, the CCGS, our Cancer Center Support Grant, that is a mandatory component for that. If you can get leadership on board by talking about why the study or project you want to do is important, because it advances health equity for whatever population, this is something that promotes their goals of achieving health equity. And this is how you leverage leadership to help you to get your project rolling out.
That's absolutely right.
Yeah, so I just want to personally thank each and every one of you for being here today, and for the amazing work you're doing in our community and being those advocates. So thank you. Like I said, if you have other questions, we're all accessible.